High quality nursing care is obviously crucial to the delivery of a high quality service, and sadly many of the complaints I've heard about in connection with Stafford have concerned the behaviour, performance and attitude of nursing staff. Wide-ranging questions are raised by what happened there, but it is apparent that there is a general sense of unease about the training, resourcing, discipline and organisation of nursing.
I think we have to teach people research methods and we have to teach them how to care. It's not, you know, you're 18 years old, if you've got very little life experience, you know nothing. So caring is something, it's a skill that can be taught, and they have to also have really good role models because they want to be able to observe what good caring looks like.
And there was discussion at the table about how hands-on is the curriculum at the moment. And there is a lack of understanding, and I think this is a public problem, that there is a 50-50 split between theory and practice, that there are 2,300 hours of theory in the programme, 2,300 hours in practice. But practice does mean that the NHS and others are really heavily involved in the quality of who qualifies.
We've talked about training and development of nurses, and I think the sense was that having a graduate profession was the right way to go, but there needs to be far more done around how nurses are supported in learning about basic care in the ward environment.
We assume that most nurses go into it with the idea that they're going to help people, and somewhere along the line just common humanity seems to go very often, whether it's whether it's the degree course, whether it's just too much to do or whatever, but even quite often that general feeling that they started out with somehow seems to diminish over the period of that first element of their training, very often, if you don't have the right culture in the hospital.
From your experience, can bad nursing cultures be turned around? And what do you think are the secrets to that?
You have to constantly challenge the culture in your own organisation. You have to constantly be open to others coming in to do that. What's important, I mean, I've just gone into an organisation, UCLH, I've not been there very long. You go in there and you see what people have got used to being the norm, and you have to challenge it. So I think organisations have continually got to expose themselves to external scrutiny. We do that in UCLH, not only, obviously you've got CQC, but we have the chief nurses, a group of us, 9 of us in what's called the Shelford Group, meet and we challenge each other's practice and we invite each other into our organisation so that they can start to challenge those norms, things that become normal to us that become unacceptable elsewhere.
We talked about the role of healthcare assistants. There were different views about regulation and indeed what you mean by regulation. You said that you weren't in favour of formal regulation of healthcare assistants, or whatever you decide to call them. Would you be supportive of some national competences and accredited training?
Absolutely, definitely. My worry with regulation is that it's seen as some sort of panacea that will solve a problem, when the reality is about training and competency and assessment and variation. So if there was such a thing existed as a national programme, then I would be very supportive of that, yes.
I think as the group here has indicated, there's much more commonality and consistency that people would like to see around job titles, competencies and training. There's more of a debate about whether the next step is also needed about formal registration. And linked to that, it was also important that you highlighted that nurses are reminded of the conditions of their registration, about their roles in delegation to others that support them.
We also mentioned the code of conduct, and nurses are judged by this, it's called code of conduct, it's how they're held accountable. But they should also feel empowered to use that code of conduct, to refuse to do things that are beyond the remit of what they should be expected to do, particularly when they're working in an environment that puts them under undue stress.
We had quite a lot of debate about the way that wards are staffed, that may need a rethink, the use of predictive tools, rethinks about the tasks, tools such as a productive ward, opportunities for skill mix and minimum staffing. No single solutions, context specific, but more of a science around it that needs to be reinforced, I think. How do regulators and boards know if they've got a safe staffing skill mix?
Ideally, organisations should have some sort of indicator that they use internally, and that can be a whole range of things, from very hard indicators, which are, you know, the number of falls, the number of pressure ulcers, etc., that might occur on a patient or in a ward at any one time. It's also other intelligence that you would gather, such as complaints, you know, verbal, non-verbal, written, patient experience, what people post on websites. There's a whole range of knowing how you're doing, and the important thing is that you collect that and you take notice of it and you take action as a result of it.
I think we would need to agree what sort of set of early warning signs that they would need to look at. You know, for me, there's something about other variables apart from just the staffing numbers and whether it's qualified or unregistered nurses looking after patients. There might be other things going off in that environment that would give you some sort of warning that your care might not be the right, or not being supervised at the right quality. So, you know, is there a gap at ward sister level? Is there a gap at matron level? Something that's not policing the system might be something that you begin to think, actually, I need to worry a little bit about that.
Would setting minimum staffing numbers guarantee better outcomes or patient experiences?
Not necessarily. And there's a large body of evidence, predominantly from America, which suggests there's an association between more registered nurses and better patient outcomes. But we have to be very cautious about interpreting that evidence, because there's all sorts of other things that could have affected those outcomes. It could be that when you have more nurses, those nurses are working in organisations which have more resources, which have a culture which focuses on outcomes. So it's not just the number of nurses, it's all sorts of other things which impact on outcomes as well.
We've had a lot of discussion this morning about the role of the ward managers, ward sisters. Are there changes that you think that trusts should consider to strengthen that role?
One of the things we did when I came into post about 10 years ago was to ask the ward managers exactly what would make a difference for them to enable them to deliver the job that we felt they needed to do in the ward environment. And they were very clear to us that the two most important things were to put them back into navy blue, because they'd gone into a grey, very anonymous uniform, which they didn't like, and certainly was not easy for staff or carers or patients to identify with. So we did that. And they also asked to be made supernumerary. So over the last 10 years, we've now released our ward managers so that they are supernumerary, and we've also supported them with action learning sets, and we've paid for them to do managerial courses, etc., and we've had them shadowing, etc., senior nurses across the organisation. And we're now at a stage where it's my view as a chief nurse that we have a reasonable expectation of those ward managers now to deliver the professional agenda.
We've heard lots of discussion about the need to refocus on behaviours, what's desirable, acceptable, and crucially non-acceptable, and for the profession to make sure that the non-acceptable performance was weeded out. And we heard also a suggestion that perhaps those behaviours perhaps ought to be reflected in the re-registration requirements.
I think there's two things. If I could have my dream, there's probably two things. One is I think we need a standard final exam where nurses are of the same competence academically and clinically at the end of their training, and we know exactly what comes out is what we want. The other thing I think we must have is a proper post-registration career pathway with definitive points, both academically and clinically, as they move through it, similar to medicine.
And then finally, we've heard a lot about nurse leaders, whether it's about nurse directors, whether they're chief nurses or non-executive directors, how they're supported in their roles, and the very important role that chief execs play in reinforcing their role and status within the board, within their organisations, and emphasising again that it's not just nurses in isolation. They are there as members of clinical teams, and the more that we can see our boards having a majority or a significant proportion of clinicians on those organisations, the more that those conversations will shift and be more around the clinical issues and delivery of care to patients.
In this room, I sense, and I've been really grateful for the speakers and the contributions that have been made, not only are the great and good of the profession, the nursing profession, but also as a group of people, that if you put your heads together and you got out there from your palaces of good practice, you personally could turn round lots of other places. You know lots of people who behave and act as you do. I'm quite convinced of that as well. And frankly, it is people like yourselves who can do far more about turning this problem than any report I can issue or any particular action that could be taken by the Secretary of State. So the start must be the people there. We want, I would have thought, to reconnect the nursing profession as a whole, so that the values that you all aspire to and everyone else thinks they aspire to become the same. And one message perhaps I got today, which has slightly surprised me, is I sense perhaps a need to think again about how nursing is described, how there is more clarity about what nurses do and what those who are not nurses perhaps do. So I take away from today a positive experience and a feeling of optimism that problems can be solved. But what I wish to emphasise is that it's not me that's ever going to solve them, fortunately, it's you. Thank you very much for coming today, and I have been immensely helped by what you've had to say.